to the Stanford Clinical Lecture Series in Radiation Oncology. Доброго вечора, слава Україні. So this is the text number to text to get the CME credits for Stanford physicians. I'll also post it in the chat. So our today lecture is on CyberKnife, SRS, SBRT. CyberKnife is dear to our heart here at Stanford, as it was invented here by Dr. John Adler. Now we have two CyberKnife machines and mostly treating brain SRS and spine SBRT and some other intracranial malignant and benign diseases. Our speakers today are Dr. Scott Soltis and Gregory Залковський. Dr. Soltis is a professor in radiation oncology and neurosurgery. He's also a world expert in radiation oncology and CNS malignancies, brain and spine mets. He gave us an excellent first lecture in this lecture series on GBM. And today he will talk on SRS and SBRT for brain spine mets, meningiomas, trigeminal neuralgia, etc. And Dr. Ґреґ Залковський is a clinical assistant professor who recently was hired by Stanford after completing his residency at University of North Carolina, Chapel Hill. Ґреґ is a very active member in the CyberKnife physics team, optimizing and automating processes there. He will talk about more of the technical aspects of CyberKnife, planning and delivery. But first we'll start with clinical part of the talk by Dr. Soltis. Take it away, Scott. I'll stop sharing.
Okay, great. Thank you for that introduction. Yeah, so Ґреґ and I will tag team. I'll do this first part for about 30 minutes. And then I think he has about 20 minutes, and then we'll have some time for questions. So let me see. Is that good?
Yeah, looks good.
Okay. So this won't go into too much depth. This is more of an overview of some of the areas in the brain and spine that we will do radiosurgery. And actually, we will go into depth regarding the most common indication for radiosurgery, which would be brain metastases. So part of this talk will be kind of more didactic in knowledge, and so that things that I would teach the residents, and then also just a general overview of what we do. Okay, these are my disclosures. They're not relevant for today's talk. And just to make sure we're on the same page, when we refer to stereotactic radiosurgery, the stereotactic part of that name refers to a localization system relative to known 3D reference. And historically, that has been with a frame-based system that's screwed into the skull. And then your internal target is in reference to that external frame. But the CyberKnife and other mask-based systems or optical guidance, that's relative to the patient's own anatomy. For example, in CyberKnife, we do skull tracking predominantly, or bone tracking, either in the skull or spine. For other nomenclature that can vary around the world, I'll use the term radiosurgery, which in the United States means stereotactic treatment over 1 to 5 days. Some people consider radiosurgery truly 1 day, and then hypofractionated radiosurgery 2 to 5 days. But there's some variability in that nomenclature. Same way, I'll call this just spine radiosurgery, but it can also be called SBRT or SABR. But the key theme is that there are stereotactic principles that are combined with high doses. And with those high doses, for example, for brain and spine metastases, it's changed our treatment intent with, for example, whole brain radiation. That's just short-term palliation of brain metastases. And changed it to definitive local control through ablative doses. Or for benign tumors, it just, changes our treatment course of 6 weeks of daily fractionated treatment to potentially just 1 day. So it's potentially easier and perhaps less side effects. So we're all familiar with the dosimetry of whole brain radiation. Again, if you do whole brain radiotherapy, the chance of a tumor growing back at that same site is perhaps 30 to 40%, whereas with radiosurgery, the dose escalation allows a better local control on the order of progression of just about 10%. And perhaps this is most well seen on spine treatment. So here's a traditional two-field, AP/PA dose plan. And you can see that the hot spot of the plan, the 105% in orange, is not in the target. It's either in the posterior soft tissue or in this case, it's in the bowel. But with radiosurgical dosimetry, we can put the high doses in the target, minimize doses outside of it, and then that allows for dose escalation, and you should have better local control. Okay, so with that introduction, let's look at where we will be going over these next 27 minutes. We'll touch on each of these, and I would like to spend a little bit more time on brain metastases and radiosurgery, because this is the one area where we actually have a lot of data and a lot of trials to potentially talk about. So this is kind of more a little bit deeper depth and the didactics of this talk. And we'll first review how we got to where we are now, like what are the past trials that led to most all patients originally being treated with whole brain radiation, and now most patients have a data-based rationale for treating with radiosurgery and omitting whole brain radiation. So how did we get here? What are the past trials? I tell the residents this, like, there are many, many trials, and you don't necessarily need to know the specific details of the trials as long as you know some of the key themes. And if you know the key themes, then you know what the answers are to the trial. So here are some of the key themes. If you have resection of a brain metastasis, surgery alone is not adequate for tumor control, and you need some form of radiation. And if you don't do radiation, the chance of the tumor growing back at that surgical site is around 60%. So what are the data for that? Here's 3 large trials that we know. The Patchell trial, surgery alone with or without whole brain radiation. Coker had the same arms, and then the Mahajan trial is surgery with or without radiosurgery. And you can see that local progression occurs up to 60% of the time, and this is improved with the addition of either whole brain radiation or radiosurgery. So that's one theme. Here's kind of the main themes for the addition of whole brain radiation. So there's 2 components of treatment in the brain. You can do whole brain radiation, or you can do a local treatment, meaning local surgery at an individual metastasis, or radiosurgery at an individual metastasis. So if you add whole brain radiotherapy to a local treatment, it has never been shown to improve OS, is overall survival. When you add whole brain radiation to a local treatment, it does improve local control. We just looked at that for surgery alone. It likely improves the rate of new metastases appearing in the brain. And if you omit whole brain radiation, the chance of a new brain met occurring is about 50-50 within 1 year. And possibly whole brain radiation improves neurologic death. This is the chance of dying due to intracranial progression. But I think we had some recent data that shows maybe that's not the case. So that's kind of a split argument there too. We have 2 trials that show improvement in neurologic death rates. So what are the data? Oh wait, I'll hop to the data in a second. So that's the whole brain radiation key themes. The converse of this, adding local treatment, either surgery or radiosurgery, to whole brain radiation. So everyone gets whole brain, you add surgery or radiosurgery. That does improve survival if the brain is one of the main problems. So that's people who have good performance status, or if they have a single metastasis. And lastly, the key theme is that intracranial progression, we know, leads to cognitive dysfunction. Whole brain radiotherapy leads to cognitive dysfunction. And there used to be debates about which was worse, but we now have multiple trials that show whole brain radiotherapy, even though it decreases the chance of progressing in the brain, it leads to worse cognitive dysfunction than tumors progressing in the brain. Okay, so if you know that, you know all of these trials, and I won't spend too long on this, but you can just see that I tried to make the summaries for all these trials similar. So this is this is everyone gets whole brain radiation, but you add either local treatment with surgery or radiosurgery, and that does improve survival if you have good prognosis. This is local treatment where everyone gets that and you add whole brain radiation. You can see the summary is the same. Overall survival not improved, overall survival not improved, and so forth. These are all the trials where that look at cognition. So despite an improvement in intracranial control with whole brain radiation, the arm that contains whole brain radiotherapy has worse neurocognition. And you can see that in all of these. And here are the data for neurologic death. In 2 trials, it's improved. In the last 2 trials, it has not been improved. So that's still up to debate. And all this led to Astro in 2014 now. This is kind of an old slide. They said, do not routinely add whole brain radiotherapy to radiosurgery for brain mets. So you can see, I kind of show this frequently over the years, and every couple of years we can check a certain box off. So you can see for 1 to 4 metastases, that's what's shown. All those trials I showed you on that last slide were for 1 to 4. What about for more than 4? And we used to not have data for that, but we now do. So where are we now? Where radiosurgery is the new standard of care. All those old trials were for so-called limited brain metastases, but obviously limited is a subjective term. And why do we even care about number at all? And many people would argue the number does not matter. For example, in this patient, what is worse for survival? Someone with 10 brain metastases that are each 1 centimeter, or someone with 2 brain metastases? Again, we can control each one of these 90% of the time. So the person on the left is at a higher risk of a tumor growing back because it's she has more. But in fact, the person on the left has better survival. It's not the number of metastases, it's the volume that matters. There are many, many studies that show the volume of tumor correlates with survival, whereas the number does not if you control for the volume. So that led to this study of radiosurgery alone. This is not randomized, but it's prospective. Radiosurgery for 1 to 10 metastases. And the survival for 1 is better than more than 1, but survival is not inferior for 2 to 4 compared to 5 to 10. So if you're going to do radiosurgery for 2, then you have justification to do it for 10 if survival is your endpoint. So we can check that box now. Yeah, we're okay on time. So what about this? We looked at the Patchell trial. The standard of care following resection of a tumor is whole brain radiation. But all that changed with this trial. This is N107C. The standard arm was surgery followed by whole brain radiation, and the experimental arm was post-resection radiosurgery. The endpoint was cognition and overall survival. So by the key themes, we already know where this is going. Whole brain is not going to improve survival, and it's going to lead to worse cognition. And that is what is seen. So with whole brain radiotherapy, despite a nearly doubling of total intracranial control, survival is the same, cognition is worse. And that led to the conclusion that radiosurgery should be considered one of the standards of care. And I usually emphasize, I considered it the standard of care. It's the winning arm of a randomized trial. Okay, so we can check that box. So what about more than 10 metastases? And that's really where we are right now. That's an unanswered question in regard, as far as having actual phase 3 randomized data. But before I touch on that, I'm skipping ahead of myself. So another unanswered question is, have we optimized the sequencing of radiosurgery and surgery? I already said that the standard of care is post-resection radiosurgery, but we have reason to believe that pre-resection radiosurgery, so you do radiosurgery first and resect the tumor that day or within a week or so, that may have better outcomes for a variety of reasons. So this is an ongoing study. It's open at Stanford. Now to the point about radiosurgery for more than 10 metastases. That's an unchecked box in this graph. And there is a trial looking at that. This is CE7, whole brain radiation versus radiosurgery for, this has actually been modified. They'll allow any number of metastases. So we hope to have an answer for that question. A common question is fractionation beneficial for radiosurgery? And recall, this is single fraction cavity radiosurgery in N107C. And I would argue that this local control is low, it's poor. It's actually worse than with whole brain radiation. This is not exactly the case, but we'll go with that. And it's low because here's our series. This is from Archie Column, where in our hands with over 500 resection cavities, our local progression is not the nearly 40%. It's only 7% here. Part of that may be that most of our patients were treated with fractionated radiosurgery. So with that and other background, the follow-up to N107C is this trial where the standard of care is single fraction post-resection radiosurgery, and the experimental arm is fractionated radiosurgery. So we'll have an answer at some point if fractionation is beneficial in the post-resection setting. If for intact metastases, we have retrospective data that fractionation may help. Here's a study in metastases greater than 2, and if you fractionate, despite having a nearly 50% larger volume, this group found better local control and less radiation necrosis. So basically, what we would expect with some of the standard R's of radiobiology. But this is retrospective, and we'll be opening this study next year. This is a prospective trial, single fraction versus fractionated radiation for intact metastases. So we'll have an answer to both of these. So in the absence of data, this is what I tend to do. I do single fraction radiation per RTOG 9005, and anything that gets much above 2 centimeters, I usually start to fractionate. But again, we have no prospective data for this. So in conclusion, kind of went through the last several decades of the evolution from most all patients getting whole brain radiotherapy to most all patients getting radiosurgery. The how many brain metastases can be considered limited is variable. Like we routinely will treat 20, 30 brain metastases in a single setting, and we're waiting for prospective data on this. And we went through these trials that are ongoing. So with that, we'll transition to metastases in the spine. And there are two main trials for this. One was negative and one is positive. There's a variety of reasons that this could be the reason why this is negative. And I won't get into it too much, but just know it wasn't even a negative trial. The external beam radiation arm had better pain control at 3 months, which was the endpoint. This started in 2006, and there were some learning points involved in setting up this trial. And this is a more modern trial in Canada. Again, external beam radiation, 20 gray and 5 fractions versus SBRT, 12 gray times 2. Similar endpoint, complete response at 3 months. And this was a positive trial for the primary endpoint at 3 months, but also you can see it's a durable pain control, like out to 6 months. There's a doubling of pain response. There's a tripling of local control. So the conclusion is radiosurgery is superior in this trial. Honestly, I don't do radiosurgery to the spine for pain control necessarily. It's really for durability. If someone has a good prognosis and I want them to have durable local tumor control and therefore pain control, then I would do radiosurgery. If it's just for short-term palliation in someone with poor prognosis, then 8 gray and 1 is the right choice. Okay, with that, I'll take a break for a question. Or do we have this? Not today? Yeah. All right. So phase 3, level 1 data exists for all of these except. Normally, you're not allowed to write a accept type of question, but this is our own talk, so we can do this. But this wouldn't fly for normal, Astro and things like that. So which ones do we not have data for? How does this work? Do I need to unshare or? Okay, perfect. Yeah, excellent. We hope to have data for fractionated radiosurgery, but we do not have that as of yet. And all the other ones we do. Thanks. Oh, yeah, here we go. So let's move on to benign tumors and benign entities that are not tumors in the brain and spine. And I tell the residents basically if it's benign, my doses tend to be like 14 to 16, except for some exceptions. But for schwannomas, meningiomas, pituitary adenomas, paragangliomas, so a lot of these omas all get like 14 to 16. For schwannoma, vestibular schwannoma, we go a little bit lower dose because of potentially for hearing and also for facial nerve toxicity. For non-benign meningiomas, we give higher dose. Hemangioblastomas, they need a little bit higher dose, it appears. And you can see the rest. For AVMs, arterial venous malformations, we usually dose those just like a brain metastasis. So just pretend it's the same size as a brain met and give it that dose. So what are some of the data here? These are older slides. It's still for vestibular schwannomas, 12, 13 gray gets you something above 90% control, depending on the time point. 14 to 16 gray gives you something above 90% control, again, depending on the time point. Benign tumors occur in the brain, benign tumors occur in the spine. And this is our experience as reported by Alex Chen. 149 tumors, you can see the details there. But the punchline, again, if a patient has never had radiation to that site, the tumor control is something above 90%. So it looks like benign tumors in the brain and benign tumors in the spine all have the same outcomes. And here's just an example of a patient where this is a somewhat risky place to have surgery, especially in an 82-year-old woman. It was growing, so we treated it. This is the tumor, the MRI. We defined the cord with a high-resolution T2 MRI. So that's cord. And then if it's right on the cord like this, I do tend to fractionate. It's a benign tumor, so just be a little bit safer. So we did 24 gray in 3 fractions, which is the green line, but at the tumor cord interface, I limited the cord to 20 or 21 gray, and you can see that here. And then you get a really steep gradient. And again, I guess what's not immediately obvious here, with the CyberKnife, my PTVs and PRVs tend to be 0. More honest, I think the overall machine accuracy is, say, like a 0.5 millimeter. The image fusion is about a 0.5 millimeter. But we just generally don't use PRVs and PTVs. Tumors not near the spinal cord are easier, just 14 to 16 gray. The cord's not really at risk, and we would expect 90+% local control. Here's a patient that has a meningioma. So her cord is severely compressed. So she is not a candidate for radiosurgery. So with any, powerful tool, you have to know when not to use it. And this is someone that should not have radiation. So she went to surgery and her symptoms got better. Another part of discussing radiation with patients with benign tumors is the risk of secondary malignancy. In our spine trial reported by Alex, we had 776 patient years and no secondary cancer. The best data are in the brain, and it's this series, which is updated every couple of years. It's now over 100,000 patient years. So like one patient followed for 1 year is a patient year. So this is a lot of data. And they do see cancers in these patients, but the rate of getting a brain cancer following radiosurgery is the same as getting brain cancer if you did not have radiosurgery. So they say it's not at an increased risk. That said, I usually tell patients there's probably like a 1 in 10,000 risk of a secondary malignancy from the treatment, which is about the same as the background rate. So whether it's increased or not is debatable. Okay, so those are benign and malignant tumors. What about other entities? So we do routinely do functional radiosurgery. All of these are standard of care indications for radiation. Trigeminal neuralgia is probably the most common with us. We do 75 gray times 1 to a segment of the nerve. Here's the CyberKnife type of technique as reported by this Italian group. You can see overall the chance of pain going away and staying away is about 80% out to 5 years. And then if these people do progress, you can repeat the treatment and then you end up on this red line. So it kind of looks the same efficacy the first time and the second time. Here's another standard of care, non-experimental indication for radiosurgery. and we're trying to expand this program at Stanford. Here's an example: 72-year-old man. He's right-handed. He has a very severe essential tremor. These same data apply to people with Parkinson's disease that have a tremor. Here's an example, one way to test them. So this is his left hand. That's not good. The goal is to stay within the lines here and draw an Archimedes spiral. But on the right hand, his dominant hand, it's even worse. He can't even put the pen onto the paper. It just shakes when he has that intent. So what we do is various measurements based on the anterior commissure, posterior commissure. We target that. In this case, we give 130 gray times 1. Here's the treatment plan. Patient starts to get a little bit sign that you were there 3 months later, but then you really do get a lesion sometime within a year. And then when you see them back, so we treated the left side, his dominant hand, which would be the right side drawing, and he can now trace the Archimedes spiral. He can stay within lines, he can eat, he can brush his teeth, he can hold his grandkids. So it's a very rewarding treatment for us and for him. We looked at other things. We have a depression protocol. So this is not standard, but this is on protocol. So people are experimenting with radiosurgery either as an ablative tool or a neuromodulation tool concept. This is a standard of care indication. If you have a hamartoma in the brain, which is causing seizures, we can treat that, and that helps with seizures. Patients with obsessive compulsive disorder, there is actually a randomized trial. Turns out this trial was not statistically significant, but there's a thought that there is a split in the outcomes here, but the baseline rate was a little bit different. So this was actually a negative trial, but we just need more data. And it's indicated. It is a standard of care through the American Psychiatric Association. We do 135 gray. This is our target, and this patient of mine did get better. His obsessions and compulsions got better. You can do functional radiosurgery in the brain. You can do it in the spine. We had an old trial of targeting for back pain, and it actually worked. So we're thinking about how to explore this a little bit more. Okay, question break number 2. So for non-malignant conditions, radiosurgery is a standard of care. It's not experimental for all these things except. Yeah, that's right. Okay, and just one slide on this. This is a trial Dr. Rahimi and I will be starting next year for people with refractory pain. Like pain medicines don't work, nothing works. There's old history of neurosurgical, injury or removal of the pituitary gland, and there are groups that can target the pituitary gland, and people say it's actually shocking, within hours or days their pain gets better. So we're going to explore that here at Stanford, and there's interest in this. Okay, so I'll conclude with this. Radiosurgery is the standard of care for most all patients with brain mets, selected patients with spine mets, any benign tumor, AVM, trigeminal neuralgia, or tremor. Great, thank you.
Thank you so much, Scott. That was an amazing lecture. Thank you.
Yeah, thank you, Scott. So I'll go into how we treat this on cyber. So you can see my screen okay?
Yeah, we can see it.
Yeah, so I'll just be talking about the technical way that we deliver all those doses that Scott talked So as an overview, I'll go through the cybernetic system itself, and then I split this into basically two sections for brain planning and spine planning, which are the two main sites that we treat here at Stanford. Again, you can treat other sites such as lung and liver, but we have less practice with that, so I won't talk about them here. So the cyberknife itself is a single energy 6FFF X-band LINAC. It has a fixed 1000 MU per minute dose rate. It is attached, basically it's an industrial robotic arm that allows it to have a lot of degrees of freedom in moving about the patient as opposed to the single concentric arc of our standard LINACs. And then the imaging itself is 2 orthogonal KV images. Each of these imagers has a size of about 20 by 20 cm that's projected to ISO. There's the two main, the F7 is the most recent model, the M6 is the model before that. We have both of these here at Stanford. They come with either a 5 or 6 degree robotic couch for positioning accuracy. So we have there's 3 main collimation systems that you can have on the cyberknife itself. The standard that comes with all cyberknife systems is the fixed collimators. These are, again, machined tungsten that you can place inside the head of the machine. These are the most precise and most reliable, as they have the least amount of moving parts and they're a fixed size. But they do require the therapist to go in and change the collimator every time you want to change sizes. And the way the delivery works is each collimator basically has a different path set, so it is less efficient than the fixed iris aperture, which you can see in this image here, which has this sort of hexagonal shape. You can move through the same collimator sizes as the fixed cone. But again, this is less repeatable than the fixed, so we won't use it for the smaller collimator sizes, the 5 and the 7.5. But otherwise, it is more efficient than the fixed collimator. And then the final add-on you can have is the MLC. This is a maximum field size of 115 by 100 millimeters, with 2 banks of MLCs with a 3.85 millimeter leaf width. We'll talk about this more in the spine section, but this is good for irregularly shaped tumors and is generally, for those larger tumors, more efficient in terms of delivery time while giving equivalent or better plan quality than the iris collimator. So there are 4 main tracking modes for the cyberknife system. 6D skull, which is our main one for brain tracking, and then there's several different ones for body tracking. Excite spine is the main one that we use. Excite lungs is again specialized for fiducialist lung treatments, and then fiducial treatments for anywhere that you want to have implanted fiducials. The synchrony system, which is kind of demonstrated here, where the robot will actually move along with the implanted target, can be used with either Excite lung, the prone version of Excite spine, which you don't use here, as well as fiducial tracking. So our tracking accuracy is within 0.95 millimeters, so sub-millimeter. And again, for our planning purposes, if you're using 6D or static fiducial or the Excite spine, we won't add a PTV margin since they're directly tracking on the target or the skull. But if we're moving away from where our tracking center is, we'll go over this in a bit more detail later. We'll add a 1 millimeter margin per 5 cm difference between where our tracking center is and where our target is. And then for synchrony, there's some debate in the literature about what exact margin you want to use if you're using this motion tracking. But I think the most regularly used one is a 5 millimeter uniform margin. For simulation, you want to use a smaller slice thickness, generally below 1.5 millimeters. We'll use 1 to to 5 millimeters generally. For those functional cases where we want to have a higher resolution, such as trigeminal neuralgia, we'll use a smaller 0.625 millimeter slice thickness. Since we are using non-isocentric beam or planning, we do want to scan further than we typically would on an external beam. We want to make sure we have at least 15 cm superior to verify we're not getting high dose passing through somewhere distant from the target. And then these are just our standard setups for our different main sites. Brain and then upper C-spine, we want to have head neutral and then the thermoplastic mask. The acuform helps with the neck immobilization. T1 through 4, we'll have head extended. This helps us kind of avoid the chin while we're trying to treat that upper T-spine. And then for most of the spine, we'll want to have arms at the side posterior to body. This is so we can block beam entry through those without blocking our lateral beams. And then for very low L4 to Cossacks, we'll have the arms on the chest, and again, back bag. Contouring for brain, fairly standard as you would do for external beam planning. Your organs at risk are optics, brainstem, and the cochlea. For cybernetic planning, we'll typically use the precision auto contouring for the start, and then we'll refine it if needed, especially for treating something that's close to these structures. You have the option of doing either brain, head, neck, or spine to the anatomical region. Just as a note, if you are using the brain anatomical region, it's set up to use the fused in T1 MRI as the active secondary. And again, tuning structures, rings for conformality. Optics, we'll generally try to avoid sending beams through the optics if we can avoid it. Again, sometimes if we're close, we have to. Oral and chin avoid to avoid any uncertainty if the mouth is opens and closes if we don't have a tight fit on the mask, and to avoid any dental artifacts. And then an inferior void, especially for younger patients and for benign targets, will block any beams from exiting directly down, so we don't have any of that extra body dose to reduce any secondary cancer risk. For setting up the alignment center for skull, we'll typically want to have a 10 to 20 millimeter margin on the superior and anterior skull to allow for kind of some variation in the tracking. We do want to avoid the lower jaw that can throw off the tracking algorithm if it moves. And then having this kind of posterior curvature also helps the tracking system. In general, for most of our brain planning, for targets that are not close to any of those organs at risk, we're primarily concerned with conformality and treatment time. And then again, any avoiding overlap with any other plans. In general, our recommended collimator selection is we want to have the collimator diameter to be around 2/3 the smallest dimension of the target. Is usually a good starting point. We will change this depending on the case. So for example, if we really want to push conformality, we'll use a smaller collimator size. If we want to increase the delivery efficiency, especially if we're treating a large number of targets in the same plan, we may add in a larger collimator. And these are more for efficiency's sake. For fixed, we'll usually only use 1 to 2 collimators to kind of minimize the having to split the plan into multiple paths and having the therapist have to go in and change that collimator. For IRS, we have more flexibility because we don't have those concerns, but we still want to keep a reasonable number of collimators. The optimizer starts having issues if you give it too many degrees of freedom and becomes a bit less efficient. And then for targets, once we get above about 35 millimeters in diameter, especially if they're not regularly shaped, that's when the MLC starts to give us a similar plan quality while giving us a reduced plan time. So we'll switch over to that. All right, first of my questions. For a trigeminal neuralgia case, what would be the most appropriate collimator selection? Something I have to do to have the question pop up?
Yeah, unfortunately, I lost the ability to launch it. Sorry about that.
Oh, no worries. So since we can't answer, the correct answer is the 5mm fix. For these functional cases, especially trigems, they're a very small target, and we're very concerned with having good conformality. So we'd want to use our smallest size. And then for the iris, we're, oh, there it is. Well, I just told you the answer.
Sorry about that, yeah.
No worries. But again, just to go through the other answers, for the iris, we generally want to avoid using these smaller sizes because we're less trusting of the repeatability at the small size. MLC is not great for very small targets. And then again, we want to use our smallest field size, 5mm. As Scott mentioned, we do treat a decent number of targets occasionally in the same course. Once we get above 5 targets, we'll have to split that into multiple plans to keep our treatment time below about 60 minutes. Our typical rule of thumb is it's about 10 minutes per target that you're treating in a plan. So for larger targets, you're usually a bit more efficient, and then for small targets, you're usually a bit less efficient. And then for splitting into those multiple plans, our first grouping is going to be by size. This allows us to use a small number of collimators per plan. Again, this is less of a concern if we're able to use the iris collimator because we have less overhead for switching collimator sizes. And then for distance, it depends on what you're more concerned about. If you're more concerned about efficiency and being able to optimize directly on the overlap dose between the different targets, then we'll generally want to group close targets. If your primary concern is lowering the daily volumetric dose, then we can split them into the close targets into different groups, and that will lower your daily like V12. And then for targets where we're very concerned about conformality, things close to or in the brainstem, we'll treat that in its own plan to allow for basically us using all of our beams and all of our available treatment time to get that conformality. These are, again, our general rules of thumb, which are definitely overridden by any particular case. We'll generally shoot for 98% coverage for brain mets, 99% for other cases such as schwannoma. And then our prescription isos line, we shoot for 70% plus or minus 5. Again, for schwannomas, we're a little less. Our conformality index, we'll aim for about 1.5. Our GI is a bit dependent on the target size. This is mostly because once you get below 1 cc, it becomes a little bit difficult to meet this 5 for your GI, even with our smallest collimator sizes. And then again, we're aiming to get below 60 minutes for treatment time if we can. And then our thirst constraints will typically use the Timothy tube. And then moving on to treatment delivery, we'll usually have physics and MD presence at for every treatment. Verify that we're within our close distance. The machine does account for shifts up to 10 millimeters and up to 1 degree or 3 degrees, depending on which angle it is. But we want to start as close as possible so we don't have to use that correction if we can. And then we'll want to verify that the alignment is consistent with reported shifts, just to make sure that our tracking algorithm is accurate. One thing to note is if you're reviewing these at the station, the CyberKnife applies only the translational offsets. So you do have to eyeball a bit whether the rotational offsets make sense. And then if it's not consistent, then we usually will have to adjust the imaging parameters. So again, this is a case where you can see there's a little bit of a difference between these facial structures between the blue, which is the acquired image, and the white, which is the planning image. But the CyberKnife is fairly confident that we're not that far off. So in that case, you could change the imaging parameters to get better agreement in this area. So for this, we decrease the KV and increase the MES to give us better contrast while maintaining the same image quality. Again, this is primarily a concern with patients who have thinner skulls, who've had surgery to have some of this resected, or pediatric cases. Well, it's a case-by-case basis. And then moving on to spine. These organs at risk, these will vary a lot depending on exactly what level you're on, because again, that's going to change what's in your near proximity to the spinal vertebral bodies. But you always will want to have the cord or cauda contoured, and then again, if needed, esophagus, small bowel, stomach, kidneys, anything that can get close that we're concerned about. An additional thing for spine that we use, it's not necessarily required, but it's to use a tracking contour. This tells the system where the vertebral bodies are and which ones to pay attention to when it's doing tracking. This will make a bit more sense when we get onto the treatment delivery section. But in general, for setting the alignment center, we want it to be within the targets. And then centered on the brightest pixel. This helps with the tracking algorithm because it normalizes the image based on what's at that imaging center. And then the ROI size, this box, we want to make sure we're covering have a good amount of features within this box that will allow us to track, while not extending too far that we start tracking, say, curvature or motion of targets that we're not actually treating. So in that case, you'd want to use a smaller region of interest. For some cases that we're treating that are outside of the spine, we don't want to place our tracking center directly in it. We do need a fair amount of features for our tracking to be accurate, and something like the iliac crest is not going to give us very many features. So if we set our tracking center here, we probably would not have very good tracking accuracy. So again, we use the closest area that has a good number of features. In this case, if you have to move particularly far away, greater than 5 centimeters, we start looking at using a PTV margin to account for the uncertainty in the tracking, mostly the rotational uncertainty of the tracking as you start getting that far away. And again, we are limited in our field of view from the imager. So if you get too far away from your alignment center, you're not going to be able to really see what you're treating, which is also can be an issue. And then for upper C-spine, for particularly C1, we'll switch over to skull tracking, and we'll occasionally use that for C2 and 3. Again, just because that will be a better surrogate for tracking than the spine itself. And again, on the planning side, for the majority of cases, the MLC is going to give us the most efficient plan with the highest plan quality. So there are some cases where if we're shooting to the small target, we'll want to use the fixed collimator. And again, we'll want to block any beam entrance to anything that is outside of our field of view or that might move, such as the arms. And then my second question. Again, so when selecting the imaging alignment center, what is the most important consideration? Yeah, so the correct answer was the ROI covers a feature-rich area that tracks to the target. Again, the sensor being within the target volume is not always the best idea for targets outside of the spine. And the brightest pixel is nice to have, but it's not required. And then again, for CyberKnife planning, we don't work in ISO at simulation, so it's not important that we align with that. Again, plane evaluation for spine. Our kind of general rules of thumb for the 20-in-1 that we'll use, the D-min of 15. Again, CI less than 1.5. Generally, our target is large enough that we can use the gradient index of 5. And again, treatment time under 60 minutes. For treatment delivery, again, we want to make sure that the alignment matches well with what the machine itself reports. A particular issue for CyberKnife is, especially in the T-spine, you want to verify that you're tracking on the right vertebral body, which is a bit more difficult since we only have these 2 planar KVs to work off of. And since, according to the CyberKnife, most of these look fairly similar, it will let you track and treat on the wrong vertebral body occasionally. And then this is just showing the context view and then the full view. So this is why we set that tracking ROI. So this is the image that the CyberKnife system is actually going to use for tracking itself, is just this reduced field of view area. But you still can reference the entire DRR for verifying that you're at the correct level and things like that. And then again, you want to make sure your ROI that you're tracking in is large enough to have enough features in it that you can have accurate tracking, but small enough that you're not influenced by any flexion of the spine. And that's all I have.
Thank you so much, Ґреґ. Excellent talk. So I'm opening the floor for questions. So while people are preparing, I'll ask a question to Scott. So you mentioned that maybe number of mats does not really matter as a number, but more of a volume. Some volume of all the mats matters more, right? Brain mats. My question is about cost effectiveness. Has anybody done the cost effectiveness analysis to define maybe that number or the volume?
Oh, I see. Like number versus volume and like survival.
Right, survival and then all costs associated with treating the patient, cost to the patient itself, right?
Yeah. Not that I'm aware of. Yeah, so we did not, like, I didn't touch on cost because yeah, if you do whole brain radiotherapy, you're less likely to have intracranial progression requiring new repeated courses of treatment. So from a societal cost, like insurance cost, yes, whole brain would be cheaper. But like true comparative effectiveness, cost effectiveness models would you would put a cost to the impact of cognitive dysfunction. And I don't know, I'm not I'm sure people have done that, but I don't have the data right on the top of my head there. So yes.
What's the maximum you treated here? How many mats did you treat maximum?
I don't know. That's a moving number. I mean, we routinely would do 30, but sometimes you think you have 30 and then they get a scan and they have something more than that. Yeah, I see. Yeah, go ahead.
This is like, I think is the maximum we treated is like a 65-ish.
Yeah, that was Dr. Hancock.
I see a question in the chat. Do we do SBRT for radioresistant metastases such as melanoma or renal cell carcinoma? Yes. Because, yeah, well, radio resistance is a concept for small fractions per day. So like 30 and 10, it doesn't appear more or less that radiosurgery, that anything is radio resistant to radiosurgery. Colon cancer is the worst, so we do dose up a little bit on that. Yeah, so it's a stronger indication for large doses rather than 30 and 10. And then re-irradiation, yes, we do re-irradiate spine, re-irradiate brain. So.
Any other questions?
I have a question for Scott. Currently, we are not giving you data on the total brain dose. So, I mean, like for example, the value at 12 gray. I'm just wondering, are you looking at it, and do you prefer us to give you some data on that? So for the multiple meds.
I mean, yeah. So brain V12 correlates with radiation necrosis. It makes sense for like one tumor, but I don't think it's not logical, you know, the tumor on the left side and the tumor on the right side, that you add up those V12s and then that correlates with some risk of necrosis at both sites. So I think it works for one tumor. I do use like V12 type equivalents for AVMs and things like that. But I largely don't look at V12s for multiple meds.
Oh, sorry, Scott. I was going to ask, because I think I saw some webinar where they were talking about this. They'll do like a shell from the med and then look at the V12 independent, like for independent lesions. Like, is that something you would like or no? Again, you don't really care so much.
Yeah, I personally don't use it too much. But there are data that where necrosis correlates with that.
I guess sometimes what I struggle with, I know I've talked to you before about it, but when we have lesion, like if you're treating 20 brain meds and then you might have like 2 brain meds pretty close to each other, and then trying to decide if I want to fractionate or slightly dose reduce that area. I still kind of struggle with that. So I don't know, I might ask for that ring and then look at the B12 and then decide if I want to slightly dose reduce or fractionate. I don't know how you think of it, Scott.
Yeah, I think it makes sense to determine the risk of necrosis and dose and local control of one med or a cluster of meds, or basically a small area. But I think we need just more data. Like, is bridging dose, is that bridging the V12 from 2 meds next to each other, bridging, is that different than like a peripheral V12 all the way around a tumor? Like there's a lot of things that we don't know. So I largely don't look at it too often.
There's another question in the chat. Thank you for a great lecture. How do you recommend between single isocentric VMAT versus CyberKnife in case of multiple meds, more than 10 lesions?
Yeah, our radiosurgery practice is almost wholly, 100% CyberKnife. So I can't comment too much about single isocentric VMAT for multiple meds. I know many groups do that, and they have good data, good dosimetric data on that. But we don't do it, so I can't really comment too much.
Leo or Cynthia, do you want to mention anything about VMAT?
I can comment a little bit. So we do have a backup program for the our SRS program, the Selena on TrueBeam SRS. But we do add 1 millimeter margin on the GTV to compensate the uncertainty. So because we believe that delivery is not because during the treatment we are not closely watching. And potentially, like also like the uncertainty it exists. If you cannot zero it, there's no robot or something to compensate that. So 1 millimeter margin around that. So comparing 1 millimeter margin with the on Saba knife, no margin. This is not comparable. So that's why we always prefer to do it on Saba knife. But I cannot comment like if other place is treating without a margin. If they do that, then it becomes comparable. In our place, it's not comparable. A Saba knife is a better choice.
There's also a limit on the size of the mat, right? We cannot
Right.
treat very small mats.
Yes, on
with
the
tubing.
LINAC, we did a measurement already. If the size of the tuba is less than 1 cm, the dose uncertainty is actually more on the LINAC side because it's not the properly commissioned for a small field.
Mhm.
Yes. So basically, if you want to do very small lesions on the tubing for Lima, you actually have to have a specific small field model in Eclipse to be able to accurately predict it. Another thing is that we did use a Vision RT to continuously monitor, but then the patient will move, and then like Lei said, even if you see it move, then you won't be able to compensate it like the robot did. So, and then sometimes the LINAC head will actually block the camera. So then during those times, then it's harder. Also for the LINAC, if you actually have the lesion that's about 7 centimeters away from the central axis, then you actually have to add additional margin because then the dosimetry actually based on our own the MEU and Lori's measurements using a Phantom, that the delivery for anything that's a little bit further away from central axis is not as accurate. So.
Yeah, thank you so much, Cynthia, for the comments. If there are no more questions, I will end the session. Thank you so much to the speakers. It was an excellent session today. On Friday, we'll have a talk on head and neck oropharynx. See you Friday. Thank you.
Natalia.
Bye-bye.
Bye.